I'm Jenny Robb. I'm a consultant clinical psychologist based in CAMHS. I'm also the clinical lead for psychological therapies in CAMHS. So yeah, you need to press it again, sorry. So just revisiting that Thrive model, which we've all been talking about this morning. So the area in which CAMHS, and this is specialist CAMHS, is based is around the bottom sort of half of that circle. So it's the getting more help and the getting risk support. So just to help you understand that that's kind of the level that we're talking at. So it's kind of a stepped process, but obviously there's some fluidity across the different segments. Okay, if you go on to the next slide. Okay, so who should be supported by specialist CAMHS? And this is not going to be an exact science. So that's the first bit that I need to say, that this depends on the type and the severity of the presentation. So if you just press the slide again, Louise, thank you. So types of mental health presentation that we'd be talking about, there's a list there, and I'm sure that there's no surprises in that list. But we're not just talking about the presentation, we're talking about the severity as well. There's another type of presentation, if you just press again, Louise. So again, I'm guessing that most parents here will be aware that in terms of types of neurodevelopmental presentations, if there is a reasonable indication that a child has complex neurodevelopmental difficulties, for example, or autistic spectrum continuum or ADHD, then they can request a multidisciplinary assessment from specialist CAMHS as well. So if you go on to the next slide. So in terms of severity of presentation, so again, as I said before, it's not an exact science, but what we're talking about is that lower sort of half of the circle in Thrive, and these are young people up to the age of 18 with considerable levels of mental health difficulty. And I can hear you all saying, what's considerable levels? So if you just press again, Louise, please. So these young people may have already accessed some support at an earlier stage of the Thrive model, so there are earlier presenters today. That doesn't have to be the case, that isn't a prerequisite, but it just might be the case that people have already accessed some support and they're feeling that they need something more, or there's a request from those earlier providers that actually something is needed from specialist CAMHS. Again, Louise, please. So we're talking about emotional problems which significantly affect a child's daily life and have persisted despite probably a school or a community intervention, and probably despite parents and family trying to do as much as they can to manage the difficulties. Just again, please, Louise. So an example would be a deterioration in academic performance or not attending school as a result of a mental health difficulty, significant social withdrawals, so not going out, not engaging in previous friendships, relationships, serious risk-taking behaviour, and when mental health has a significant impact on physical health and well-being as well. So you just go on to the next slide, please, Louise. So which presentations would not be included? So we talk about normal, in inverted commas, reactions to adverse life events, for example, anxiety and distress following a bereavement or a divorce. Now, again, this isn't an exact science. And when we refer to something that's a normal reaction, we're really aware that there's a lot of subjectivity and judgment that comes into trying to make sense of what is normal. And I think what we say is, we kind of look at this on a case-by-case basis. So sometimes if it's a reaction to an adverse life event, it's about watch and wait and see how this kind of develops over time. Is the young person processing the experience? Are they able to move forward after a certain period of time? Or are we talking about a prolonged grief reaction or a real sort of deterioration in functioning over a significant period of time? If you press again, Louise. So difficulties which are normal to children's development, and again, we're using the word normal, but I guess there's a lot of subjectivity around this, and there'll be clinical judgment in this as well. But when we talk about temper tantrums in younger children, we would think that that isn't representative of something that would be that would trigger specialist CAMHS input. Likewise, independent struggles between teenagers and parents, general independent struggles, we would think of that as part of a normal developmental trajectory for a young person. If you just click again, Louise. So difficulties which could also be helped by other services, so services that work in schools or in children's centres, youth in mind projects. So there's lots of other services out there that can be considered, and it might be that those services can be accessed more easily, or that they're more appropriate for the needs of that young person. So I think what we're really clear about is that We don't want to do more than is necessary. We don't want to get involved if that young person's needs can be met at a different level. So that's really important to consider when we're thinking about specialist CAMHS referrals. Next slide, please, Louise. Oh, sorry, yes, also minor self-harming behaviour in the absence of suicidal ideation. We wouldn't consider this to be necessarily something that a specialist CAMHS service would need to get involved with. So again, it might be within a context of a recent adverse life event, but if we're talking about minor self-harming within the context of lots of other complicating factors and complex presentation, then obviously that might lead to different type of consideration in terms of a referral. Okay, next slide please, Louise. Okay, so this just demonstrates kind of visually about our duty and filtering process. So referrals come into our service, they come in via, we have a standard referral form which is on our website. They come in from lots of different primary healthcare professionals, and also we have a duty line which is 9 to 5, Monday to Friday, and people can call our service and speak to a clinician based within the teams. So the referral comes in, and then on the day or within 48 hours of that referral coming in generally, there'll be a triage process, and that triage process might involve a telephone call to the family, might involve a telephone call to the referrer, and that'll be about assessing the information that's been passed through on a referral, understanding risk and understanding the level of urgency of that referral. Then the referral is either allocated or can be triaged out of the service to another service, more appropriate service. So once the referral is allocated, then a first comprehensive assessment appointment can be booked. And from that appointment, there'll be an understanding of what might be behind the presentation. So really trying to formulate what the difficulties might be. And we have lots of different pathways and teams within CAMHS, which I'm going to talk about in a minute. But it might be that at that point, a young person's care might be passed to a different team or a different pathway within CAMHS that feels appropriate for their needs. Alternatively, it might be that at that point of that sort of comprehensive, detailed assessment, that actually the referral might be redirected at that point because we might not feel that we're the appropriate service. So if you just move on to the next slide. And if you just click that again, so that, there we go. So this is just some examples of the teams and the pathways that exist within specialist CAMHS. So it's understanding that these come under the umbrella of specialist CAMHS, but they have specific approaches within each team. They have there is some overlap in terms of clinicians, but also there are clinicians that purely work within some of the teams as well. So you can see that we've got a whole range of specialist teams within CAMHS, and the reason being that, you know, those clinicians and those pathways are developed to meet that specific need, so that we can hone those services and we can ensure that they are as responsive and that the clinicians are as skilled as possible in that way of working. Next slide, please. Okay, so just a word about crisis support. So the specialist CAMHS crisis support, we have a crisis team, and they will work with young people when they present in kind of like an acute crisis state. So they could come, they will respond on the day or the following working day that a referral is made, and often this is when a young person might have been admitted to an acute ward following an overdose or an episode of serious self-harm or a real expression of suicidal intent. And this team are very skilled at risk management and understanding what is happening in the here and now around a young person's mental state. So they will assess very quickly, very rapidly, the young person's levels of risk. They'll provide mental state examinations, and they'll develop a risk management plan. And that's very much developed alongside the young person and with their carers and their family. So to be a really collaborative, thought through risk management plan. The team also provide a review appointment in accordance with the risk assessment and the management plan to check in a number of days later about where that young person is at, what might have happened in the intervening time. When the crisis team isn't available, because it is generally a 9 to 5 service at the moment, then first response will cover the needs of the young person outside of these CAMHS working hours. And then as soon as it is feasible, the worker from the crisis team will support and will assess that young person.